Well, we're going to go ahead and get started. My name is Annie Luetkemeyer, and I'm in the HIV ID Global Medicine Division. And I'm a clinical trialist and also run our San Francisco Infectious Diseases Research Center. I'm going to be giving a therapeutics CROI report back along with Monica Gandhi. I'll do the first half, and she'll be doing the second half. I wanted to share disclosures that I have gotten research grant support from several entities, and I was a PI on some of the studies, and or an investigator in some of the studies, and I will call those out along the way. So I'm going to talk about a couple different areas. Doravirine and islatravir studies, there was a lot of interest in these, and we'll orient to both the treatment and the switch studies. I'm going to talk about broadly neutralizing antibodies when they're given with a second agent. So two different studies that looked at this that we'll give you updates on. And then hepatitis B reactivation in the CNIX cohort, and an outline of how to maybe think about making sense of Hep B sparing regimens as we move forward into this exciting area. How do we manage the hepatitis B part of this? So I'm going to start by just a quick orientation, because I'm going to talk about islatravir and paired with other drugs. Just a reminder that islatravir is an NRTTI. So this is a new class of drugs that acts in a similar way to the NRTTIs by chain terminating. And as we've heard about in other grand rounds presentations, we remember that at a higher dose, there were some issues with white cells and CD4 cell counts. Now it's at a reduced dose, and it appears that that has resolved this. This is paired with NNRTIs, so non-nucleoside reverse transcriptase inhibitors. So doravirine is one we're going to talk about. This has already been approved. And then there's a cousin of doravirine that's ulonivirine. I'm not sure if I'm pronouncing it right, but I'm gonna own that one. And it's an investigational NNRTI with a longer half-life. I'm far away from my organic chemistry days, but you can tell that it's a little more tweaked than the doravirine. It's a cousin, not a direct brother, I would say. But anyone else who with a more organic chemistry can jump in and correct me on that front. Okay, so this was a pretty interesting study. I'm going to start by talking about use of doravirine and islatravir in treatment-naive folks, and then move on to talk about switch. So this is a study that was presented by Jürgen Rockstro, and then I'm going to show you the citation on the next slide because it was published the same day. So this was randomizing people who are treatment-naive to get either doravirine, islatravir taken daily orally, or BF-TAF, which I'm going to call BIC in the future, and try not to use brand names, but I may fail down the road. People could not have had treatment they could not have had resistance mutations, and I'm showing what the doravirine resistance mutations are here. They also excluded people with NRTI resistance mutations, including M184V, but this was because of the BF-TAF, because at the time the study started, that still wasn't in the package insert. We'll talk about what there is an impact of M184V on islatravir, but islatravir generally still retains efficacy, so that is not the reason that M184 was excluded there. So I wanted to point that out. What they presented at the conference was 48-week data for primary efficacy endpoint, and that's what I'm going to share with you today. This is the link to the publication, so lots more detail that's in here. But the bottom line is, when you look at the viral load by snapshot analysis, that this was equivalent. So the blue here is doravirine, islatravir, again, oral once a day, compared to BF-TAF, and there was equivalent viral suppression. And then we always want to look at, well, who didn't do well? So there were 6 folks who had a viral load above 50 in the doravirine arm, and 9 in the BIC arm. And I'm going to get into that a little bit on the next slide. So treatment emergence, we always want to understand when people don't do well, what are the consequences of this? So as I mentioned, 6 in the doravirine islatravir arm had a viral load of greater than 50, but that doesn't mean that all of them met confirmed virologic failure or had issues here. So 1 resuppressed, they didn't meet genotyping criteria. 1 was lost to follow-up, but the resistance testing they had didn't show anything that was an issue. 2 had viral rebound, but there wasn't doravirine islatravir in their blood. It doesn't work if you don't have it on board. And then there were 2 who did have resistance, and importantly, and I'm showing you some information about them, they both had pretty high baseline viral loads. This is kind of our first signal for using this combination in treatment-naive patients. So we're just trying to understand what the limits might be, so intriguing to see that both of these folks, one had a 2 million viral load and one was 1.5 million. So what did it look like? The mutations observed at baseline, these were these were not exclusionary mutations. This person had low doravirine, the first one had low doravirine and islatravir levels at week 4. And then you can see that they had an emergent M184 I, and they also had a Y188L, which knocks out doravirine. So the interpretation of the phenotypic shift there is doravirine, no longer susceptible, but islatravir was below the 20-fold change cutoff there. So is expected to still retain some efficacy. The second person had normal doravirine islatravir levels, and they also had treatment emergent doravirine mutations, as well as an M184V, still retained islatravir susceptibility. So gives you a sense that when people failed, some of the viremic folks did develop doravirine resistance, and then M184 emerged and may have had a small impact on islatravir, but below the level that, again, is predicted to impair islatravir function. So I think we need to learn more. Both of these folks were switched. So what can we say, when you're thinking about, well, this is new, what are the benefits here? Is there anything that we're getting out of a new combination? Well, do they perform differently? I didn't go into all of the safety data, but you can, in the paper, see there was similar efficacy by subtype and by low CD4 cell count, similar CD4 increase. So this concern that islatravir might be impairing CD4 from a higher dose in the past, I think we can let go of. No difference in weight gain. I think a lot of hopes that this combination might affect weight gain more in a more beneficial way. And both this study and then prospective ACTG study for people who were switching didn't show a change. Similar safety profile and no difference in lipids. So again, equivalent, and BIC is good, but you didn't see a benefit here. And just to say, what are the, I raised when things go wrong and people have adverse events. There were 2 serious treatment-related AEs with islatravir. One was DRESS, so eosinophilia, serious drug reaction, and one drug-induced liver injury. These are very uncommon. They did occur. It's just worth keeping an eye out for things like this. As I mentioned, what are the differences? Gosh, is this a signal that islatravir might have an issue with potency at a high viral load? I think we need to learn more, but this is our first look at in a treatment-naive population. And as we're going to talk about in many of these studies, there's no hepatitis B activity here. And as is very similar to others registrational trials, many folks were not vaccinated, right? So surface antibody and core antibody negative in about half of the folks. And as is not surprising, some people got new hepatitis B infection. And this is, there were 3 new infections that were reported in the islatravir group. And 2 of them resolved on their own and they didn't change, but one of them did lead to a treatment change. So just a reminder to all of us as we get excited about these medicines, that it's always a good time to vaccinate people for hepatitis B and be aware if we're switching them. And we'll talk lots more about this today. Well, what about switching, right? We have more data on switching folks. That was the naive data, which I think was exciting and new. And there's 2 switch studies that look at taking people on either on BIC currently, or they're on whatever their background ART is, and switching them to doravirine and islatravir. And the figure on the left is people who are either stay on BIC or switch, and that's the 052 study. And the study on the right is the 051. They're on whatever their current ART is that's suppressive, and they switch to doravirine islatravir, or they stayed on. And on the left-hand side in 052, you can see, and this is looking at 48-week data. Sorry, I think it's 48-week data, right? It was virologically equivalent there. People maintain, so green is doravirine islatravir, and purple, maroon is BIC, and they were equivalent there. The other switch study was a little bit more confusing. It went out to 96 weeks, and you could be in one of 3 groups. You went right on doravirine islatravir, you stayed on your current ART, and then you had the option to roll over. So people were either on 1 or 2 years of doravirine islatravir. I'm just showing the 96 I'm showing the 48-week and the 96-week data at less than 50. They also showed it at less than 200. And what you can see is, again, green here is doravirine islatravir, but then they flipped it, so it made it a little bit tricky. So green and blue are doravirine islatravir, and purple now is background ART. And you could see that doravirine islatravir both maintained a high virologic suppression, maybe slightly better than the background, but certainly this was in the realm of equivalence. So looks very reassuring ensuring for people for virologic efficacy in terms of their ability to remain suppressed. What about treatment emergent resistance? This is a busy slide, but I'll give you the top line here, which is in the switch to BIC-TAF. There were 5 people who had a viral load greater than 50, but only 1 had resistance. They withdrew before viral failure was confirmed, but they were able to do resistance testing. And they did have doravirine resistance as well as islatravir. There was an M184B, but the fold change suggested that islatravir would still be effective. But nonetheless, this was a new emergent mutation. In the other group, there were 7 folks who had a viral load of greater than 50, but no resistance was detected. And in group 2, there were 2 with a viral load greater than 50. So no emergent resistance mutation there. So this is really a signal. We got 1 person where you had DOR and islatravir resistance that happened. So this is uncommon, but it can occur. Again, this is just a high-level look at safety. No lymphopenia was present. No big difference in lipids, weight gain, and renal function. Maybe a little bit if you looked at one versus the other, one way of looking renal function versus the other. But all in all, I don't think there was a big difference. Comparable AEs, we didn't see any of the DRESS or eosinophilia. And then Hep B, I'm just bringing this up again, that, we had 4 new Hep B infections in one of the arms and 1 in the other one. And then importantly, when there was reactivation in folks who were core antibody positive, suggesting that they'd had prior now controlled hepatitis B. It was low-level viremia, but none of them had a poor outcome with this. So we don't love to see this, but it's reassuring that this was not clinically significant. They were both asymptomatic. There was 6 total, and they were all asymptomatic. So what's the take home here with the new naive study and now the 2 switch studies? So I think generally well tolerated with comparable viral suppression and tolerability profiles. Viral failure with treatment resistance is rare, but when it occurs, people can lose doravirine, and then M184V can emerge with a decreased fold change to islatravir, but still probably preserved, although not sure that you'd be giving islatravir with, but that could have consequences for other medications. So it's an NRTI sparing option. It may be an attractive switch option for older patients who you're trying to get off tenofovir or abacavir for whatever reason. Monica's going to share with us some other exciting switch options in the same population. And I think from my perspective, having options is better. You just want to be able to tailor your treatment to people, particularly as they age and have other comorbidities and drug-drug interactions. Not FDA approved, going before the FDA in the spring, and so we look forward to hearing more. But from my perspective, using this type of combination in a weekly combination might be a little bit more attractive, as some people have expressed a desire to take medications in a weekly way. And so we know that one size doesn't fit all. This may be possible, so stay tuned for weekly oral islatravir being given with ulonivirine or ULO. And there were some data presented that I'm not going to go over today that suggests that they may have complementary resistance profiles. So when there's resistance to one, the other may have a little more efficacy and vice versa. So that's always nice to see. And there's a phase 2 clinical trial that's underway with data forthcoming that looks at weekly dosing versus randomization to BIC. So more to come, and hopefully we'll have data for this over the summer. All right, I am going to switch gears and talk about broadly neutralizing antibodies for a minute. I actually have on my wall, and Steve was just telling me this is unnecessary, but that's how we often have discussions. I find the broadly neutralizing antibodies confusing, so I like to get myself oriented. So I thought I would share with you how I orient this. There's the envelope that sticks out of the HIV virus of virion, and there's multiple different targets that these broadly neutralizing antibodies can attack, and that's how they exert their efficacy. So they can go in the CD4 binding site. The B3 glycan are some of the common ones. So I like to think about when I hear this word salad of all the different BNAbs, what are we talking about and where do we act? Steve said, why do you care? What difference does it make? Well, I don't know. It just kind of helps me to organize this as a framework in my mind. So maybe it will help you. So as I talk about these next 2 studies, I'll let you know where the BNAbs act, and you can decide whether or not this is useful. So this is CAB being given with one BNAB, and it's a CD4 binding site BNAB. So it's monthly IM cabotegravir that's being given with N6LS, and that's the CD4 binding site monoclonal broadly neutralizing antibody. It now has a name that's called lotivibart, and it's given every 4 months. And in this study, which is called the EMBRACE study, they looked at it at given IM or subcutaneously. And the idea with sub-Q was maybe you can avoid all the hassles of having to place an IV, and this would be a way around this. The spoiler alert is that sub-Q was not very well tolerated, and they're not going to be going forward with that, but they will go forward with the IV. Oh gosh, that's a typo there. That should not be IM, it's IV. So I apologize. Yeah. That's my fault. So there we go. So who do they enroll in this study? This is a switch study. So these are people who have been stable on HIV, ART, and they can't have had any resistance to cabotegravir in the past. But importantly, they had to get resistance testing for the monoclonal, for the broadly neutralizing antibody. And I point this out at the bottom. Hopefully people can see this, but they had a 50% screen failure rate due to failure or resistance of the BNAB assay. And in the people who resulted, so if you got a test result, about a quarter of them had resistance if it resulted. So I think that that's a structural barrier that we're going to have to think about with the BNABs, that you have to send out a test. And at least in the current iteration, it doesn't always run. And then people can have some inherent resistance just naturally here. What they're presenting here is the secondary endpoint looking at month 12 of an FDA snapshot algorithm. So what do they find virologically? And just to orient you, the red is the IV broadly neutralizing antibody, the navy is the sub-Q, and then purple is the oral standard of care. And so you can see that the IV actually, had pretty good virologic suppression, similar to the oral standard of care, and the sub-Q was a little bit lower there. These numbers overall, though, are small. This is a phase 2 study. We had these data from before, but I'm just including them here. And on the right-hand side, gosh, Annika, can I get the little pencils like right where on top of the slide? It's all right. I mean, that's just telling you the cabotegravir cutoff fold change is greater than 2.5. So to orient you. So what happens in the IV folks if they have virologic failure? There was 2 folks who've already been reported who had virologic failure, and they didn't have any CAB resistance mutations, but they both did develop monoclonal resistance. So failed with monoclonal resistance, that's important to know. That's 2 of them. And then in the sub-Q arm, there were 3 folks. We already knew about 2 of them. One of whom had cabotegravir resistance, but did not have the BNAB resistance. And now there was a 3rd one who had both BNAB and cabotegravir emergent resistance that was there. So again, giving us a signal here that a little worrisome with the sub-Q arm that you could see CAB resistance emerging. We expect to see that you can see BNAB resistance emerging. You're not going to be reusing the BNAB after someone fails, but you do want to know about the integrase resistance here. So what are they going to do based on these data? There's a part 2 of this study that's underway, switching to cabotegravir every 2 months, and then giving the IV lotivibart, which is the BNAB, every 6 months, and only the subcutaneous formulation was discontinued. I think this is getting us closer to an every 6-month regimen, but the CAB is still every 2 months, and discussions about whether CAB can be extended for treatment longer than every 2 months. And that's going to be addressed in the Quattro study, not given with broadly neutralizing antibodies. This is going to randomize folks to Cabril, the current regimen, which is every 2 months, versus Cabril every 4 months. So giving us a sense of whether or not CAB can be extended to 4. Boy, it would be nice if it was 6, right? So that you could map it to the broadly neutralizing antibody, but that is not in the works quite yet, and may not be feasible. I'm going to give you some additional thoughts about an agent plus BNABs after talking about this study. So we'll talk about those together. And I'm going to keeping an eye on time, so I make sure that Monica has time for her comments. So Len given with 2 BNABs, and this is a CD4 binding site and a V3 glycan, right? So acting on 2 different parts of the envelope. This is known as Len-Tab-Zab. This study, primary virologic outcomes have already been presented, but this one is really just focusing on the treatment as emergent resistance mutations. So this is a phase 2 study that enrolled folks, and again, they had to. This is a switch study, so they were on stable oral ART, and they did the same thing. They had to do PhenoSense testing for them. And just to point out that 60% almost screen failed due to the PhenoSense. So 17% failed to run, and then 42% weren't sensitive. And if they did have results, it was about 50 that weren't sensitive to one or both. Do you need to be sensitive to both? That's an ongoing question with this study design approach. And it may not be the case, but I just wanted to point that out, that that's also an issue with these BNABs. So what happened overall virologically? The light blue is LEN, the dark blue is oral regimen. Similar virologic suppression here. 3 folks did have virologic failure. 1 failed with LEN resistance, which I think is worrisome. And then the 2 of them had ZAB resistance, so one of the 2 BNABs, and in one of them they kind of had to predict whether or not it was there. So not that big of a deal if you lose the monoclonals, but I think a big deal if you do end up losing LEN here. So what's the take home? IV plus 1 IV BNABs plus a second agent, generally safe and well tolerated. Virologic failure, and again, we're still learning about this, but it's generally uncommon. But when failure occurs, it can knock out the BNABs and occasionally can affect the partner drug, which I think is concerning. Getting to every 6 months dosing, which is the case with Len-Tab-Zab, is attractive, but really programmatically, I think we have to think through, should this get into the real world? It's hard enough to give people IM shots, and it requires some additional considerations. The challenges of IV administration on a clinical level are really hard. And then I think we got to really sort out this high screen failure rate by phenotypic assay. Nonetheless, understanding better ways to control HIV, particularly in a more long-acting way, I think are intriguing. And I think this is hopefully getting us to thinking about, could we give people, 1 shot a year to control their HIV? Whether it would be with BNABs or not remains to be seen, but the field of HIV drug development is not dead. So I'm going to very quickly go through Hep B reactivation and then turn it over to Monica to make sure we have time for questions. I'm really delighted to present these data that Grace Hazer, who's on vacation, very well deserved, after presenting at CROI. She put together a retrospective CNIX cohort study, and this looked at people who were taking a tenofovir-sparing ART regimen for at least 3 months during a 10-year period, which was the time that we first started having tenofovir-sparing regimens. And she looked at reactivation or hepatitis B infection. This was defined as having either a surface antigen that was positive or a DNA that was positive. And reactivation was defined by whether you had core antibody positivity. So if you had core antibody positivity and you had new Hep B in your body, then that was reactivation. If you didn't have core antibody, then it was a new infection. It was considered a new infection. And if you didn't have core testing at all, then it was either reactivation or infection. People had to have surface antigen and surface antibody testing to get into this cohort. So a lot of folks were left out because we know we don't do a great job of testing serologies, but they didn't have to have core, and they couldn't be known to have active hepatitis B. They were excluded. Just to say that 80% of folks were taking something like 3-TC lamivudine, right? So the tenofovir sparing didn't mean completely Hep B inactive, and I think that's important because these regimens, we know 3-TC, while it has Hep B activity, it's not perfect, and that there were these 3 groups of folks: prior hepatitis B infections, that was about 15% of people; no prior hepatitis B infection, that was about 57%. And I just want to point out that 40% of those had a surface antibody that was negative, meaning this was a real opportunity to be vaccinated. We don't know if they were subsequently vaccinated, but just a reminder that we should be looking at this. And then 30% of them didn't have a core antibody that was tested. And that's, again, we're supposed to do triple testing before we switch people. So good to know. The bottom line is that reactivation and new infection were really uncommon. So that is good news. And I think this is consistent with some other studies. The bad news is that reactivation can occur in folks even when their last test was surface antibody positive. And we don't know if they've lost their surface antibody when they reactivated, because it might not have been rechecked. But know that if they have a core, they can reactivate. There were new infections. I already shared that with you. You know this from the other studies. But just a reminder that when we're switching people, we need to be aware of an opportunity. And there were actually new infections in folks who were core antibody negative and surface antibody positive, so suggesting that they may have had waning there. And then there was reactivation or infection in folks who we don't know what their background status is. So reminder to get serologies. There were some missed opportunities for vaccination. How serious were these? Well, this is an observational, laboratory-based cohorts. We don't have all of the clinical data. The viral load elevations in general were low. 3 out of 18 had a high viral load that led to some changes there, so that was concerning. 3 out of 18 had a high ALT, and then 3 out of 10 had an elevated DNA. So most folks, it looks like, at least from a laboratory perspective, that this was probably not very clinically significant. But we do know that people can become very sick from reactivation, and some folks did have a significant transaminitis. Something for us to all keep on the radar. And then the last reminder that this can occur in fully tenofovir-sparing regimens as well as partially active regimens. And we saw this occur in both. So I am, in the interest of time, I'm going to turn it over to Monica. I do have an approach here, so if we share slides, you guys can see that. And I just want to make a reminder as we make the switch over here that, as I said, HIV drug development is very much alive and well. We are enrolling in some of the studies that I presented today, and we have some of the studies that are coming down the pike. So if you have folks you want to send our way, our division also has a lot of other studies, so check out our website. And thank you. I look forward to Monica's part of the presentation. Let's see if this just keeps going here. Oh, there we go. Perfect. Yeah.
Okay, so we're going to go on to part 2 of treatment updates from CROI 2026, and there's quite a bit. So we'll talk about bictegravir, lenacapavir studies, islatravir, lenacapavir once weekly, talk about 3 drugs in the pipeline, GS3242, VH184, and VH499, and then there were a lot of cabotegravir, rilpivirine real-world studies. There was a whole poster session on that. So I do think that this CROI was the CROI of the capsid inhibitor, or at least in terms of pictures of the capsid inhibitor. There was really incredible plenary by Wes Sundquist from University of Utah the second day of the meeting that showed these pictures that were really incredible. And there was a lot of commentary on capsid inhibitors. And, if we look at the timeline of HIV therapy, we are in the 30th anniversary of highly active antiretroviral therapy because it's 2026 and that was 1996. But the only thing that brought about that revolution was 3-drug ART. 2-drug ART was used before that. 2 NRTIs, not great. Like, we needed 3 drugs with PIs and NRTIs. And then we really needed the integrase inhibitors, which came about, the first one in 2008. That was raltegravir. And then we needed the better second generation integrase inhibitor, which was dolutegravir in 2013 and its cousin bictegravir in 2018. And we needed the best PI, which was the strongest PI, which came out as a single pill combination in 2018 with darunavir, TAF, COBI, and FTC. But then we entered the long-acting era, 2021, cabotegravir and rilpivirine, and then we got lenacapavir for treatment at the end of 2022. And that's the history of treatment. But now we're getting into this 2-drug question, going back to 2 drugs, but not 2 NRTIs, but 2 powerful drugs. And that's what Annie presented with islatravir doravirine, and we're going to present next for bictegravir and lenacapavir. We are in the INSTI era. We're still in the INSTI era, with bictegravir being first line in high-income countries. Dolutegravir, more than 25 million people are on dolutegravir, tenofovir, and lamivudine worldwide. And that's that second generation integrase inhibitor. But we're entering the capsid inhibitor age, or at least in terms of next week, we'll talk about prevention. But we want to think about it in terms of treatment too. And this is a picture from Dr. Sundquist's talk. It was really incredible, but it does seem, and the reason there's so much interest for treatment is that the capsid inhibitor may not just work on the capsid, like at the end of the viral life cycle. There's multiple steps in the HIV viral life cycle, and one is capsid disassembly in the nucleus, which then raises questions of maybe why it's so good for prevention, but also could it be, relatively high genetic barrier because it's multiple steps. When we think about multiple steps, we think about a higher genetic barrier resistance than just one step. So we're getting into capsid inhibitors. So my first question for you has ARS question is, have INSTIs and capsid inhibitors ever been put together before? We talk about the Artistry 1 and 2 studies that will update from CROI 2026. No, not yet. Number one, or yes, Biclen was studied in the Capella study, or yes, Biclen was studied in the Calibrate study, or yes, lenacapavir and cabotegravir have been used off-label, and there have been case series assembled. Or is it answers 2 and 3 or answers 3 and 4? Please vote. Okay, so this is excellent so far because 64% of this audience is aware, 60% that lenacapavir, since it came out at the end of 2022, and cabotegravir, since we had it since 2021, at least for treatment, and then at the end of 2021 for prevention, people have been putting those together. But the actual answer is actually Calibrate and LenCap. So it is answers 3 and 4, which 8% of you said. And that's because this Calibrate was just this weird study. I mean, actually, it was super weird. It's not going to go forth. But what I mean by weird is combinations that we can't use. Calibrate was a phase 2 study in naive participants of lenacapavir put together with other things that this particular drug company made. And since they happen to make BIC, TAF, FTC, they put it together. They compared it to BIC, TAF, FTC in the Calibrate study. It was just published in Lancet HIV. But they also put it together with lenacapavir with TAF, which again, we're not going to see that. And then they put it together with bictegravir. So lenacapavir with bictegravir. This is the first time this combination has been looked at, and there was, a high 85% virologic suppression rate in that group 2 arm. But there were only 52 people. So that was the first hint that this was of interest to that particular drug company. But beyond that drug company, we've been interested in the combination of an INSTI and a capsid inhibitor. And the only way to have done that over the last 4 years was to put together lenacapavir and cabotegravir. And this was a case series across a couple of centers, actually 4 academic centers. But what I really want to talk about is this poster that was presented at CROI 2026 from the Splash group. Nate Giston was the first author, Matt Spinelli was the last. And it was 50 people that we have in our clinic across the street who have high rates of NNRTI resistance, 70%, 10% INSTI resistance, actually. And they were put on lenacapavir, cabotegravir, with or without rilpivirine. So 46 people here were on lenacapavir and cabotegravir. That's higher than the 34 in that OFID paper. So this is the biggest case series of people on lenacapavir and cabotegravir. And at 15 weeks, there was 100%, with adding lenacapavir, there was 100% virologic suppression rate. And then one person couldn't get, but at 140 weeks, 97.5% virologic suppression rate on len and cap. So biggest case series of that, and kudos to the Ward 86 Splash team. I'm not on this paper, but that second author is my child. Okay, because he did chart review this week. Okay, so then what about Biclen? So Biclen is what was presented at CROI 2026. So there are 2 studies. There's Artistry 1, there's Artistry 2. We had gotten Artistry 2 data in a press release and even in presentation, but we got more data here, which is combination, essentially carrying Bic-Len to whatever people are on. So these are in both studies are in those with virologic suppression. I want to make a comment that it is a drug often looks good when you've switched over from virologically suppressed regimens. I mean, you've lost your WAM184V, or it's gone deep into your reservoir not to come out again. That's why the Volver studies looked good with dolutegravir over 3TC. I mean, everyone looks good when you're switching over from virologic suppression. And I challenge drug companies to give us naive data like the islatravir doravirine data, presented naive data. That's very helpful. We want to see in naives and also in treatment experienced individuals who aren't virologically suppressed. So your drug's going to look good. And yes, of course, this drug looks good because these are both virologically suppressed trials. But anyway, Artistry 1 is switching over from complex regimens, and Artistry 2 is switching over from being on BIC-TAF FTC to a single pill combination of BIC-LEN. So what did these studies show us? Well, Artistry 1, sorry that kind of got cut off, is multi-center, open label. So phase 2-3 study of switching over from whatever people were on to BIC-LEN. Now, they were complex regimens. I mean, it does beg the question why they were on such hard regimens, because we probably could have simplified a lot of these people, but they were older. Average age was 60. 28 years was the median time that they'd been on therapy, and actually 78% were on boosted PIs. So really complicated regimens. Maybe could have been on BIC-TAF FTC. That was a question that was brought up in the question answer period. But at any rate, they switched over to BIC-LEN. And there was a history of resistance. Why would you be on a complicated boosted PI? 78%. There was 66% NRTI resistance, 55% NNRTI resistance, even PI resistance, probably not to darunavir, and some INSTI resistance. And essentially, Artistry 1 showed us that at 48 weeks, going over from complex ART to BIC-LEN was non-inferior. So it's the orange here is the BIC-LEN, and also better lipids if you switched over to BIC-LEN. Again, not surprising, 78% were on boosted PIs, and maybe some of these were even on 200 milligrams of ritonavir. And so switching over to BIC-LEN did improve the lipids, total cholesterol, and triglycerides, and LDL. So that looked like, that what was really interesting that came up in question answer, and so much of going to a meeting is that question answer, was people saying, why were these patients on such complex ART? We've had BIC-TAF FTC since 2018. Could they have gotten away with being on, BIC-TAF FTC, or why not even switch to BIC-TAF FTC? And then really what came up in that point is Annie's point that she also made in the clinical session that she participated in at the end of the meeting, which is we want tenofovir sparing in some people. This is why doravirine, islatravir, BIC-LEN is of interest. Okay, so then my second question, ARS question, is how many participants evolved an R263K mutation, which we've decided in Fellows Clinic is the mutation that we think is associated with bictegravir resistance, really following up on the Mexico City data. Remember, Mexico is a more middle income country that its first line therapy is BIC-TAF FTC, not TLD. And so they have done really great work they have a central laboratory in Mexico City, and that's where most of the genotypes are run. And I ran into the first author yesterday or last week at CROI, and they were like, for some reason, their updated data wasn't accepted at CROI this year, but they would have liked to present their updated data. And it's always the R263K. Maybe with an M51, but not really. Actually, what he told me, the investigator, is it seems to be this M184V first, Nick, like we talked about this in Fellows Clinic, and then getting into the R263K. So that's the updated data from Mexico City that he couldn't present. So R263K is real, shouldn't be minimized. And how many people in Artistry 2 developed that mutation? Was it none, 1, 2, 3, or 4? Okay, this is very static at staying at 43%, think it was 2, a third think it was 1, and a third think it was 0. And the right answer is 1. So, what is Artistry 2 again? Artistry 2 is switching over from Big TAF FTC to Biclen. Biclen, by the way, is going to be a single pill combination. And I should make a mention that I'm not even mentioning this kind of other arm with different doses. The dose that's going to end up being used is Bic 75 milligrams and Len 50 milligrams. And we had a lot of questions about that, but that's it. Okay, so multi-center open label, switching over from Big TAF FTC to this Big 10, Big Len, and not as older patients because this wasn't as massively treatment experienced. And there was a certain degree of comorbidities in the population if TAF helps that, because taking off TAF helps that, because TAF isn't great for cholesterol. And what did the data show us? Really non-inferior outcomes, virologic suppression rate wise at 48 weeks. But importantly, there were some failures. It was non-inferior, but there were 4 people in Biclen who had low-level viremia, and they sequenced. They one suppressed, but they did actually have to change that person to a PI-containing regimen. So who knows? And then 2 people could be tested in Biclen, and 2 people could be tested in Big TAF FTC arm for resistance. Who knows if that person who was switched over to PI had resistance? We won't know. But anyway, 2 people got to be tested, and 1 out of 2 in the Biclen arm got an R263K. No one in the Big TAF FTC arm. So that's real. They had dolutegravir and raltegravir experience in the past, but that's real. So I'm going to call that 1 out of 383 participants a real evolution of resistance. There were 2 in the naive trial of islatravir and doravirine out of 269 that developed resistance. These are real. No drug is impermeable. That's it. Like, there's never a good drug that's not going to evolve resistance, to my knowledge. Okay, so what about islatravir? Let's take a step back, because Annie talked about islatravir, but just to remind ourselves why there's a question maybe that it has a higher genetic barrier to resistance than an NRTI. We've talked about this in fellows clinic a lot. If you have translocation inhibition and transcription inhibition, because it's an NRTTI, that's why there's 2 T's, could that 2-step process, just like lenacapavir has more than 1 step where it blocks, lead to a higher genetic barrier to resistance? We're going to have to see if islatravir and MK8527, which will be discussed in next week's HIV grand rounds, have higher genetic barriers to resistance. But islatravir has also been studied beyond with doravirine once daily, and maybe with ulonivirine once weekly. It's also been studied with lenacapavir once weekly. So these are only 52 people. This is a phase 2 study. So importantly, we have had a lot of data on islatravir, lenacapavir once weekly. The phase 2 data, we got the 48 weeks. We actually got at EX 96 weeks, but this is the final 96-week data of that phase 2 study. So it is the dose, remember, is lenacapavir 300 milligrams a week. We had discussed that once with our prep talk a couple of 2 months ago, I think, about that's the dose once a week, 300 milligrams. Islatravir dose once a week is 2 milligrams. And Annie had said the daily dose is 0.25, right? So 0.25 times 8 is 7 is basically 2. And so that's the dose once a week. And essentially there was a 48-week where there was a randomization with islatravir len versus Big TAF FTC. And then everyone got the extension phase. Everyone got to be switched over to islatravir lenacapavir once a week. These were individuals who were suppressed. So again, you always look good when you're suppressed. And the primary endpoint was looking at 96 weeks, both of these groups, people who were on islatravir lenacapavir the whole time and people who switched over at 48 weeks. So the early switch group, the HIV virologic suppression rate at 96 weeks was 88.5%. And that's actually lower, but the late switch group was 97.8%, where they got to switch over for 48 weeks. So hopefully they didn't have flags in taking that once a week, but there was actually no data in the window, which is why there was 88.5% in the early switch group. So this is small. This is phase 2. So there are 2 studies called Island 1 and Island 2. And I like how it's Island, but it's ISLEN, not ISLAN, because it's islatravir and lenacapavir. And Island 1 and 2 have enrolled very briskly. They're actually fully enrolled. So we are supposed to get the data in Rio, and I think that will be great to see the phase 3 data of once weekly islatravir, lenacapavir. And then in our clinic, let's all think about strategies like those individuals who come once a week to get their medicine. How are we going to help with once a week? Okay, so the next question is, which of the below new drugs are INSTIs? Is it VH184 and VH499, N6LS and VH184, N6LS and GS3242, MK8527 and GS3242, or VH184 and GS3242? Because our next topic is going to be the brand new drugs, like the ones that are in the pipeline, the ones that we only have phase 1 data for. And, we'll get phase 2 data next time. So 100% of you said the right answer, which is VH184 and GS3242, N6LS, which Annie just presented, is a broadly neutralizing antibody. So, there are 3. Let's talk about these 3 in the pipeline, because Annie already spoke about the BNAbs. The first is 3242. It's made by the same company that makes lenacapavir. So you'd think it'd want eventually to get to an every 6-month formulation, because lenacapavir is every 6 months. So this was a phase 1 evaluation. It's a 3rd generation INSTI. And essentially, the design was to give it either IM or sub-Q. And the PK data at least supports, you do have to have an oral loading dose. That's kind of a limitation with Len, and that's going to be here with GS3242 unless that can change. But it is looks like it can be given every 4 months. And there is modeling data in a poster, which was poster 490 at the meeting, that you may be able to extend this to every 6 months. Now, the one thing about this is that it drops the viral load like an INSTI, really potent antiviral activity. But when the question answer period, that's always the good time to really figure this out. It turned out that each injection, and there were 2 injections, is 3 mils. So cabotegravir and rilpivirine are each given as 3 mils. That they're actually each 3 mils, right? And that's fine. That's in the IM space. But I can't imagine giving 3 mils times 2 in the sub-Q space, because lenacapavir is 1.5 mils times 2. And we're already getting nodules and we're already getting pain. And so 3 mils in the sub-Q space, it's not going to happen unless they can concentrate it. So I think it's going to be IM. And that was, again, something that only came out in question answers, which is why being at a meeting is so helpful. Now, what about, and this is how quickly it drops, like any INSTI, drops the viral load. So what about VH184? You all said this was an INSTI. It is an INSTI. And here there were multiple different doses studied. So you can see that there was 0.5 mils and 1 mil and 2 mil and 2 mil and 4 mils. I don't want 4 mils injected sub-Q. So, again, think about when you're looking at the evaluation of these drugs, think about the number of milliliters and the impact on a sub-Q space. And so, there was a number of different doses. This is actually the 499 picture. So I'm really sorry about that. But I will just show the data I'm really sorry that I showed the wrong figure, but essentially VH184 looked like it could be given at every 6 months intervals. And the way that the dosing worked, it could be given every 6 months, either sub-Q or IM. Okay. And then the capsid inhibitor that was examined at this meeting in the same session is VH499. And this is the phase 1 study. And it also looks like it can be given either IM or sub-Q every 6 months without a oral loading dose. So you can see that those 2 products, because they're made by the same drug company, because it starts with V, can likely be given together eventually, because these are both every 6 months, and it's a capsid inhibitor and an INSTI. And what we really need is phase 2B study, and this is going to be called the Synergy study for 499, and it's called the Innovate study for 184, and we'll get that next year. Okay, what is one feature of third generation INSTIs in vitro? Is it, now we just talked about GS3242 and we talked about VH184. Is it that the duration of administration is every 6 months? Is that a feature of a third generation? Is it that it works against viral mutations, at least in vitro, that confer dolutegravir or bictegravir resistance? Do you need oral loading doses with both of those INSTIs, or can it only be used IM, like I think GS3242? So, excellent. So the majority said works against viral mutations that confer dolutegravir resistance. I think so. At least VH184 and GS3242 presented data that looks like, at least against in vitro generated, viral mutants that have dolutegravir mutations, N155 or even Q148, that it looks like these work against what typically conferred bictegravir or dolutegravir resistance. So I would truly maybe call these third generation INSTIs, working against those, what doesn't work for second generation. And there were 2 posters that looked at this. This is poster 521, which is the data for GS3242. And on the bottom, you can see here that GS3242 was put together. Again, this is in vitro against INSTI resistant mutant panels. And let's just focus in on, say, N155 mutation or R263K, which is hard to see, but that's the 5th and 6th column respectively. Looks like GS3242 worked here. And then the same data was presented in poster 554 for VH184. And this is a little blurrier, but essentially we'd seen some of this data before. N155 or E92Q, it looks like VH184 works. So these third generations may be helpful if we get into dolutegravir resistance worldwide or bictegravir resistance here. And then I'll just end with pointing out that there was an entire session on posters that were called Real World Experience with Cabotegravir rilpivirine. And but the Ward 86's splash data was in that poster session with Len Cab. But so is a lot of nice studies on Cabril in the real world. People are absolutely, of course, using this combination in those with and without viremia. But the reason I like this is this was a big study that looked at a HRSA-funded study of 8 clinics around the country and compared outcomes on cabotegravir and rilpivirine if you started it with viremia and without viremia. So very nicely done, really nice 3 panels. And the first, I just thought they presented it well, but the first question is, how long does it take to achieve viral suppression? Really quick. If you initiate it with viremia, we've shown that in our SPLASH cohort as well, 79% virologically suppressed by 12 weeks. The second question is, how common is treatment failure while on long-acting Cabril? Still really low, wasn't even higher in those with viremia. It was actually a little higher in those who started with virologic suppression, but that's artifactual. It's pretty much the same. And then how common are late injections? Pretty good for both groups. It wasn't like those who started with viremia had more late injections. And the fourth study, and we've looked at all these questions in SPLASH, and the fourth question is, how common is discontinuations? Absolutely, people discontinue IM drugs. They can hurt. They're just sick of it, and they go back to PO. And so there was 47 out of 344, or 14%, that discontinued Cabril, and Kat Christopoulos has shown the same thing in SPLASH. So I'll end there so that we have time for questions. Thank you. So yeah, put them in the, Anika, do you have the Zoom up for? Yeah, okay. Let me just make sure what people are asking online. And let's start with questions from the audience while I just get the online questions. Thank you.
No questions.
In the whole room.
this was just a question about that last poster. It said 31 plus or minus 7 days for on-time CAB RPV monthly. Are we saying that up to 38 days is on time now?
That's a good question. So 31 plus or minus 7 days, that is not how it was studied. It was 28 plus or minus 7 days. So it looks like they're taking some leeway here. Yeah, it's a really good question, Nikki. It should have been 28. So they did that wrong. Because at least in the original CAB-RIL trials with, Atlas and Flare, it was not supposed to be 4 weeks plus or minus 7 days. It's 28 plus or minus 7 days.
You can also, I think,
and I'm just getting on the virtual audience to see. Oh, okay. So this is for Annie.
Yeah.
Does the emergence, I'll read out loud. Does the emergence of M184V in naive people failing doravirine islatravir change your thinking about islatravir resistance?
Yeah. I mean, so I've talked to the company pretty extensively about this. I think we're all still learning, but their data support that islatravir is active as long as the fold change is less than 20. So that's what their data suggest. I agree that seeing a treatment emergent M184B or I suggests that there's pressure in that area. Their fold changes were all, I think one was like 3 and one was maybe 7, and they were all well below 20. But it does raise that question in your mind. I think what we really need is 2 things. One, understand how this works in treatment naive patients, because that's, as Monica says, that's a much higher bar. And there is a study that's ongoing looking at islatravir and ULO in treatment naive patients that does not exclude M184B. So I think we really need to understand what that looks like. And then I think if someone does fail virologically DOR islatravir, you're not going to put them on islatravir. So you're going to move on. But I do think we need to understand this a little better, particularly in the naive context. But we're right now, the full change of greater than 20 is what I understand is the susceptibility cutoff.
I would answer that too, Jeff, because you said I could weigh in on this too. I started getting worried about islatravir with M184Vs because of the back-to-back presentations of the islatravir implant. And the MK8527. And next week, Susan Buckbinder and Jaime Scott's going to talk about the prevention data. But the islatravir implant, by the time you got to the end of the dosing interval, and then they gave the macaques M184V mutant virus, didn't work. And then MK8527 concerns, that raised for me the concern at the end of the dosing interval of not working against M184V circulating virus, especially as they launch expression 10 and 11, these big prevention trials. So I'm beginning to be more worried about M184V after seeing some of the data at CROI, at least of the long acting
for 85 for the 8527.
The longer acting, anything where you're like lower dosing. Islatravir or doravirine is consistent dosing every day, but these long acting NRTTIs. And yeah, you're right. It's 8527 is the only one.
8527 is the one that I think is M184B and I are unlikely to work.
Yeah. And then other questions is, Annie, do you think that hepatitis B surface antibody titer matters? Because we don't actually measure titers so much.
Yeah. So, and I think Ingrid, if you scroll down, had a similar question about, and maybe I can lump the Hep B questions together. With a higher, did they look at the titers? So yes, the data suggests that the higher titer we know from Beehive, which is an ACTG study that gave Heplisav, which is the recombinant hepatitis B vaccine, and compared it to just the protein adjuvanted one, and you got higher titers, and higher titers predict longer lasting protection. And we know this even from old data, French data, that show that if you were boosting someone who had an anamnestic response, if you could get to 100 at week 4, that predicted them being greater than 10, like 48 some weeks after that, which is one of the guideline recommendations that nobody follows, but it is out there. It's hard to get quantitative surface antibodies. We don't routinely have access to them here. So this makes following that difficult. But if you have it, it's helpful information. I think right now we use a cutoff of greater than 10, and we know that is protective. You don't know if they're going to have an anamnestic response if you're below 10. But the recommendation right now for people living with HIV is if you don't have a surface antibody, to go ahead and vaccinate them, including if you're core antibody positive. There's a lot of debate about this around the second one, and we should study that, and there are proposals going forward to study that, but they should at least give them one vaccine and then check them. But if that's too much of a hassle, just go ahead and vaccinate them with a series, and at the end, go ahead and check it, because oftentimes it's just hard to keep track of it. And then the question was, in Scenics, did Grace and colleagues look at quantitative surface antibodies? No, we didn't have that data for everyone. Some folks did have that and some didn't. So we just didn't have that routinely for everyone. We're one of the Scenics clinics, so we weren't able to contribute that quantitative surface antibody data.
Follow up on that. In the islatravir doravirine versus the tenofovir arm, no one got hepatitis B reactivation in the tenofovir arm, right? Brad is asking.
No, yeah, they did not.
Yeah.
They did not, yeah.
Okay,
yeah.
I want to clarify what I said about islatravir and MK-8527 and M184V. I actually think it's dose dependent. That's why I think that islatravir implant data was really important. I think if you get a low dose, and again, that doesn't happen with daily islatravir doravirine, but islatravir implant, as the PK went down with islatravir in the macaque model, did not work against an M184V. So I think the problem with NRTTIs is you don't want to go too high, because you go too high and you drop the white blood cell count. But at the end of a long dosing interval, we have to think about its activity against M184V, and that would be true of islatravir as well. And then one final thing is that I think we actually have to, I think we have to end. But one other thing is, people are saying, should we save lenacapavir for protection, for prevention? Let's wait till next week, because next week, Susan and Hyman are going to talk about the 5 breakthroughs in Purpose 1 and 2 and what ended up happening with lenacapavir resistance. So I think we'll wait for next week. And then if you could please, anyone who wants to stay, we're having a CFAR report back right now. It's going to be Peter for comorbidities, Mallory for behavioral and implantation science, and I'm doing kind of impacts of funding cuts and some clinical data, and we're going to start right now once we switch over the computers. Thank you.